have been interested in the days right before death my entire life. When I was a child, my aunt started one of the first hospices in the United States. I grew up mowing the lawn of the small house that acted as its office. My mom worked there for almost 20 years in grant writing and development. My dad worked there too in public outreach. Hospice, death, and dying was a constant topic at my house. And it wasn't dark or sad in any way. It was just the service my family provided. In high school, I was on the debate team, and we had an entire debate season on the topic of euthanasia and living wills. Even though debate is a game, I learned the intricacies of what legally defines life and how the state and families play a role beside the wishes of the patient. And now as an adult, talking and teaching about cannabis medicine, people come up to me right at the grocery store, or they stop me and they ask to talk to them in their car, or they stop me after public speeches. And very often they let me know they are dying, and they want to learn about cannabis relief. I've learned to give an efficient, dry, and to-the-point response. Folks seem to appreciate that. And off they go to find some cannabis tincture with an understanding of dosing and how to use cannabis. This episode is important because dying is not cool, and there will be no marketing or information provided to cannabis folks who are dying. People who will die soon and their families need one place to get most of the information they may need to get started down this path, all in one place. That is what I'm trying to do with this episode today. If you want to learn about cannabis health, business, and technique efficiently and with good cheer, I encourage you to subscribe to our newsletter. We'll send you new podcast episodes as they come out, delivered right to your inbox, along with commentary on a couple of the most important news items from the week and videos too. Don't rely on social media to let you know when a new episode is published. Sign up for the updates to make sure you don't miss an episode. Also, we're giving away very cool prizes to folks who are signed up to receive the newsletter. There's nothing else you need to do to win except receive that newsletter. So go to shapingfire.com to sign up for the newsletter this week and be entered into this month's and all future newsletter prize drawings. You are listening to Shaping Fire, and I'm your host, Shango Los. My guest today is Dr. Sunil Aggawal. Dr. Aggawal is co-founder of the Ames Institute in Seattle, Washington, a practice specializing in integrative approaches to neurology, oncology, transpersonal psychiatry, and palliative care, and incorporating cannabis, ketamine, and other emerging therapies. Dr. Aggarwal is a fellow of the American Academy of Physical Medicine and Rehabilitation, board certified in physical medicine and rehabilitation and hospice and palliative medicine, and the immediate past chair of the Integrative Medicine Special Interest Group at the American Academy of Hospice and Palliative Medicine. He is clinical assistant professor at the University of Washington School of Medicine and a member of the Humboldt Institute for Interdisciplinary Marijuana Research. He is also currently an associate medical director of Multicare Hospice. Dr. Aggarwal has been qualified as an expert in cannabis and psilocybin medical and religious use in county, state, and federal courts. His education, associations, and publishing are extensive and can be found at amesinstitute.net. Sunil has previously been a guest on Shaping Fire Episode 3, explaining the geographical history of humans and cannabis. Today, we're going to be discussing integrating cannabis medicine into end-of-life care. Welcome to the show, Sunil. Welcome back.
Oh, it's so great to be back, Shango.
Well, let's get right into it and make clear what we're actually talking about today, because, a lot of us have heard, our friends and family and even the news talk about end of life care. But, except for the idea that, that person's probably reaching the end of life, we don't really have a real grasp on what that might be. So when caregivers use the term end of life care, what exactly are they saying?
Well, end of life care is in this country usually happens in hospice care. If most people, when they are facing end of life, means in hospice, your prognosis is you have a medical condition which 2 doctors certify that you might have 6 months or less to live. So it's kind of a care when you know that somebody is near the end of life, and how do you manage the care such that you maximize the quality of life with the time you have left, and that involves a whole range of skill sets from the caregiver standpoint, from the medical system standpoint, from the family standpoint. That sort of all falls under the umbrella of end of life care.
So how far away from death does a patient have to be to I don't know, qualify for end of life care, hospice treatment? Because, in a certain way, we're all terminal, right? But there's got to be a window where it's so close that the strategy changes.
Yeah, that's right. I mean, that's why I mentioned hospice at the get-go, because this really is how we build our system of care. So hospice is sort of the most intensive, like palliative. That's another term I want to let your listeners know about is palliative care, which grew out of hospice. It was the type of care. Palliative means to cover or to cloak, and so it's a medical specialty. It's where you're working on symptom management, really high quality symptom management, supportive care, looking at physical, emotional, psychological, spiritual suffering. We call that total pain. And so that type of care happens most intensely 100% in hospice. That's like palliative intensive care in hospice, and that usually happens at a patient's home, and the team comes to them. And also is available by phone or telemedicine in these days. So that's kind of and that really is a benefit that anybody is eligible for. Like I said, if two doctors say that they are potentially 6 months or less to live, no matter what medical condition that might be.
I see.
Go ahead. Yeah, sorry, I was just going to say earlier than that. So now, but people know that even patients need some kind of palliative care much earlier than in being in hospice care, and certainly anybody, and you're right. I mean, we could all benefit from greater quality of life and better symptom management and care for the total pain that we experience in our lives, which is a very holistic model of care, and definitely that's something that anybody can benefit, no matter their age or illness status. But the medical field of palliative care has decided to focus its efforts on patients with anyone who has what we call a serious or life-threatening illness, and so that's at any stage of that illness. So that could be years before somebody might reach their death. We don't really know, but it is that patients can still be eligible for that kind of care. Even though they're not in hospice, it just happens in a different way.
It's interesting that definition that you gave us for palliative care, where it is care that is more holistic and taking care of the whole human instead of just, let's say, the chemistry and mechanics of the body. When you describe that, I thought to myself, well, hell, that's the kind of care that I wish I was getting from my doctor my entire life. And it's just not how we tend to do things in the United States, which is interesting, because, our general fear of death in total. You hit on palliative care and you hit on end of life care as far as definitions go. But since so many people use the term terminal care, why don't you hit on that too? And your answer maybe is the same thing, but specifically, what do people mean about terminal care for folks who are listening and they're trying to decipher what their doctor is telling them?
Sure. I mean, terminal, if you get a diagnosis, the doctor says you're terminally ill, that just means that you have a diagnosis of an illness that, based on statistical tables, will lead to your death. And that there's a lot of ranges of variability in terms of, 2 years, 1 year, 6 months. There's like a lot of variation in that. But like, for example, an illness like ALS or Lou Gehrig's disease, people may live with that for many years, and the decline might be slow. That's where a patient might slowly lose muscle function, and we don't have a cure for that right now. Although there are some experimental approaches out there that might modify the disease. But so there's another kind of philosophy or school of thought where people say, well, we say the word terminal too quickly in medicine, and that really it's kind of it can be a sort of what do you call it, like arrogance, because we don't really know. There are definite examples of spontaneous remissions. There are there are experimental approaches and other types of things out there that there are people with stage 4 cancer, who are living for many, many years now with certain types of advancements that we have. So if somebody gets a diagnosis of stage 4 cancer, and they're said, well, that's terminal, they might not pursue those other types of therapies that are showing effectiveness for survival or longevity. So that's why I'm cautious with the term terminal, because of the, like I said, it implies a lot more than we really know. But it is helpful to know the statistical tables, and doesn't necessarily mean that they'll all apply to an individual. There's a lot of individual variation, so that's where that comes from. But we've kind of I think we still use it in hospice. So that's in hospice care, you do certify that somebody is, we think will have 6 months or less. But then what happens? People still get, let's say they're living longer because they're having better quality of life, and then the doctors have to recertify the patient periodically. Oh no, they lived longer than we thought. So do we still think they're terminal? And then they have to go through a process like that. So it's kind of it's a moving target.
So just for the clarity of folks, when we talk about terminal, or not terminal, but let's use end of life care in this case, we're not really looking for a solution anymore, right? Because very often on this show, we talk about, taking large doses of cannabinoids to fight cancer or, other, traditionally terminal diseases, but really by the time you're in end of life care, the goal really isn't to, okay, what are the ways that we can stop this? It's really about how can we make you comfortable? How can we make you mentally present so that you can interact with your family? How can we decrease your pain so you can experience some joy and maybe a little bit of self-actualization before your last breaths? But it's not really about curing you anymore, right?
Well, people can still have hope for that kind of thing. If they, we don't want to discourage that. You can still have that kind of care. You can have the care exactly as you described, impeccable management of comfort, family support, psychospiritual, physical health and healing in terms of quality of life. Improving your, like you said, your mental acuity, your just your physical comfort, all the different layers, and then making sure that your family is also cared for and has support. And we usually accomplish this with not just like one doctor or one nurse, but really like a whole team of we call a multidisciplinary team of specialists, like chaplains, social workers, integrative therapy, acupuncture providers, or Reiki, or there's very broad range of specialties that get involved to make that kind of care possible at the end of life. But at the same time, a patient might say, well, I still want to take my X, because even though that might be like an experimental therapy, to help a patient to see if that'll improve their the length of time that they have or slow the disease. That's not incompatible with that, and patients still have a right to explore experimental treatments even while they're on hospice. It's just generally the hospice, the Medicare, which is usually most patients on hospice are on Medicare, they don't pay for that care. They do let you see a doctor on the outside, one doctor on the outside, like your old primary doctor or somebody else. So there is a way to still have hospice care, high quality end of life care, and still explore the other aspects that you were talking about. But of course, the end of life care folks are focused on how to make that quality of life as good as possible, so that no matter what the patient is doing, that's the best possible day, and then also the people who live on after the patient, that they're not racked with complicated grief or trauma from their loved ones. passing.
Right on. So just for the sake of clarification, because of the particular audience that I have, you said that the patient may still want to be taking their X, and it's it may be an not totally researched or finished medicine or whatever. When you say X, you meant like a variable, like whatever pharmaceutical that they were getting good relief on. You are not referring to ecstasy, MDMA, correct?
Oh, yeah.
Yeah. On another show, you wouldn't have to clarify that, but on this show, you do. So we work with a whole lot of different entheogens. So,
although, I mean, certainly we can talk about entheogens and pharmaceutical entheogens like MDMA here, or the congeners. MDMA is like similar to, something from sassafras root, saffrol, and that these are, and also has it's similar to mescaline. And mescaline's been used for 1,000 years at least, and more in different types of healing, like holistic healing that we're talking about. So there's definitely like that. We can talk about that too. But I was referring to in that context, like if anybody wants to sort of use, I've had a lot of patients in hospice that continue to use different like supplements or natural medicines that are, they hope that have anti-cancer activity, for example. But at the same time, they're receiving high quality hospice care. So it's still possible to have that hope of having something to, do something about the disease process. But also being under the care of a team that's really focusing on your comfort and quality of life.
So while we're probably not going to have time to get into the MDMA mimic that you just suggested, which is like mescaline and from a root, I know that there's a lot of people whose ears just perked up like mine did. Can you just give us a quick search term for folks who want to look that up? Like what would they Google to find out more about this preparation you're talking about?
Sassafras root. Yeah.
It's sassafras. Okay.
Yeah, that was just, I was just giving an example of like it's MDMA was made by a German chemist in the early 1900s, but its chemical structure is very similar to a chemical that's been used in natural medicine for a long time, sassafras oil, an ingredient in sassafras oil. So that's all. I was just sort of tying it back to a natural congener or something in nature that it's very similar to, and then I was also tying it to the class of compounds called phenylethylamines. Phenylethylamines are what MDMA is like that, and there are naturally occurring phenylethylamine. Mescaline is your listeners might have heard of. So I was just giving you some you threw MDMA over there and talked about entheogens. So one of my interests is this class of compounds, and I think they have a huge role to play in end of life care, and we're getting lots of research studies on that nowadays. So it's even more compelling, and I'm incorporating some of that in my practice, but we can talk about that later.
Right on. So because cannabis is such a versatile healing herb, it's used for a wide range of relief in all sorts of ways, capsules and vaped and tinctures and suppositories and smoked. But, as a doctor, who still has a very active clinical life, and you are seeing patients and families all the time, I imagine that even though there's a wide range of possible uses for cannabis, that there are some that come up more often. What are these uses that come up more often that you see when actually dealing with real life patients?
Well, cannabis is widely utilized for managing the pain, managing fatigue, managing insomnia, managing like nausea and vomiting. Those are some of the. Did I mention mood? I think that there's like a whole symptom cluster that cannabis can help patients with, and that's exactly what I have seen in my practice, and encourage patients that have access to cannabis who are at in end of life care settings. It's not always easy to make that access thing happen. I know we're going to talk about that later, but when you do have access to cannabis, it can do a lot of work to take care of these really difficult symptoms that normally doctors would prescribe opioids and benzodiazepines and some pharmaceutical anti-nausea medicines to treat.
It is really interesting, isn't it? How some of the symptoms that patients want relief for are some of the more basic things that cannabis helps with, like nausea and pain and just general muscle tension, stress, anxiety about being sick. And yet, once folks start taking it for that, they start to realize all these other benefits, like, oh gosh, my IBS has gone away, or my headaches have gone away. And then suddenly now they're taking it for a much wider range of symptoms than they were originally taking it for, because once they have first person experience with it, they're like, oh my God, where's this been all my life?
You got it. That's right. I call those side benefits as opposed to side effects.
Mm. So we're going to go to a break soon. And then during the second set, we're going to talk much more specifically about using cannabis, for end of life care. But yeah, before we go, I want to make sure that we talk about how this process gets started. When cannabis comes up, do you find that it's normally you as the doctor who is mentioning it to the patient and their family? Or do you find that usually it's the patient who has found out about it on their own and they are requesting this guidance from you?
Well, Shango, I would say that the answer to that question has shifted quite a bit over the last 10. I guess I've been interacting with patients, as a professional medical student or something for almost 20 years. So the situation from the first half of my career or practice has shifted where initially where I was bringing it up more to now where patients are already know about this and are bringing it up for more specialized guidance. So it's really now of course that changes in terms of demographics that you're working with. What is the age range of the patient? What is their ethnic background? What kind of setting are they in, like in a nursing home or a hospital or in a community setting? So it's really those variables. And then now I'm in a practice where cannabis is very prominently featured on our materials, and people know me for that kind of work. So it's I end up getting patients who already know about it and are more like, well, yeah, I know it can be helpful. I've tried it, but I don't really know I need to kind of refine that, or I need more guidance. So a lot of times patients are bringing it up.
Well, actually, that's a great transition. So our next set is going to be all about refining and patient understanding of how best to use cannabis. So that'll be great. Let's go ahead and get this first commercial out of the way. We're going to take a short break and be right back. You are listening to Shaping Fire, and my guest today is hospice and palliative care specialist, Dr. Sunil Aggawal. Sometimes the topics I want to share with you are far too brief for an entire Shaping Fire episode. In those instances, I post them to Instagram. I invite you to follow my 2 Instagram profiles and participate online. The Shaping Fire Instagram has follow-up posts to Shaping Fire episodes, growing and processing best practices, product trials, and, of course, gorgeous flower photos. The Shango Los Instagram follows my travels on cannabis garden tours, my successes and failures in my own garden, insights and best practices from personal grows everywhere, and always gorgeous flower photos. On both profiles, the emphasis is on sharing what I've learned in a way that you can replicate it in your own garden, your own hash lab, or for your own cannabinopathic health. So I encourage you to follow at Shaping Fire and at Shango Los and join our online community on Instagram. As a business owner, you are incredibly busy. In reality, you are responsible for everything your company does. You've got so many responsibilities every single day that often you just don't have the time to really dig into your marketing as deeply as you'd like. You know there's more that you could do to reach out to new customers and encourage loyalty in the customers you already have, but you certainly don't have the time for it, and you're not ready to hire somebody full-time for that role either. For you, I recommend Blunt Branding. At Blunt Branding, Kirsten Nelson and her team are focused on improving your bottom line. You know, most marketing firms are excited to make your logo, packaging, and website very pretty, but they leave responsibility for improving your bottom line up to you. They don't want that kind of responsibility, but that's pretty much the most important part of marketing, right? Kirsten and her team will help you engage new customers, funnel them to your point of sale, whether it be online or a storefront, and keep them coming back to you and telling their friends. Now, if you happen to be a new cannabis company or an established company moving from medical to adult use in your state, Kirsten especially can help you. Not only is she well versed in marketing and finance, but she totally gets cannabis, whole plant medicine, terpenes, heritage farmers, and the particular needs of startups. Check out what she did recently for Moontime Medicinals in Humboldt at moontimemedicinals.com. Kirsten and her team put together a whole brand package for them, built their website, and wrote their sales materials. No doubt this is a paid commercial spot, but that does not mean they bought my opinion. I've worked with Blunt Branding on 5 projects now for various of their clients, and every single time they have done more than they have promised and over-delivered on results. I love how they generate new revenue and focus on that as the goal instead of just making a pretty logo. Similarly, every single friend I have referred them to has come back to thank me, and that just does not happen every day. Grab a pen and paper because the website address is coming up. If you want someone to implement marketing programs that feed your bottom line, give Blunt Branding a call. They will share proven techniques to increase your audience and generate sales while using cutting-edge technology solutions in the background that make all of this easy, automatic, and trackable. Go to shapingfire.com/Blunt Branding to find out more. You can also click the link in our newsletter. Blunt Branding, marketing that makes you money. Did you know that Shaping Fire has a fabulous YouTube channel with content not found on the podcast? When I attend conventions or speak or moderate panels, I always record them and bring the content home for you to watch. The Shango Los YouTube channel has world-class speakers, including Kevin Jodry of Wonderland Nursery, talking about breeding cannabis for the best terpene profile, Nicholas Mahmood on regenerative and polyculture cannabis growing, Dr. Sunil Aggawal on the history of cannabis medicine around the world, Ben Cassidy of True Terpenes on using terpenes for health in your everyday life, Reggie Gaudino of Steep Hill on the cannabis genome, and Jeff Lowenfels on the soil food web. There are several presentations from Dr. Ethan Russo on terpenes and the endocannabinoid system, and even my own presentation on how to approach finding your dream job in cannabis and why we choose cannabis business even though the risks are so high. As of today, there are over 100 videos that you can check out for absolutely free. Go to youtube.com/Shango Los or click on the link in this week's newsletter. Welcome back. You are listening to Shaping Fire. I'm your host, Shango Los, and our guest this week is hospice and palliative care specialist, Dr. Sunil Aggawal. So, during the first set, we kind of gave a little background for folks who are new to thinking about end-of-life care, so we know exactly when it is, what it is, and what it may take to get the topic started on cannabis medicine. During this set, we're going to talk a lot more about the how, right? As Sunil was talking about before we went to break, there's a lot of different ways to use cannabis, and not all of them are appropriate for each kind of ailment. Now, before we get into those specifics, I want to point out that there is no way that we are going to get through all of the different ailments and ways that cannabis can help during this show or during one of any show. And so I want to refer you to a handful of Shaping Fire episodes that we already have out that goes in depth into cannabis use for particular ailments. So here they are. So episode 22, you can learn about treating brain injury with cannabis with Dr. Ethan Russo. Episode 36 is on breathing, COPD, and asthma with cannabis with Dr. with Robert Littman. Episode 57, Using Cannabis for Parkinson's with Zoe Sigmund. Episode 60 on decreasing chronic pain with cannabis instead of using opioids with Dr. Eddie Ray. Episode 62 on satisfying sexually with a chronic disease with counselor and therapist Chris Maxwell Rose. And then the recent episode 67 on treating migraines with cannabis with Dr. Ethan Russo. So with that, Sunil, most people think of using cannabis medicine by smoking a joint, right? Just because that's kind of what the picture that they have in their head from culture. But really, smoking's not usually the proper form for most patients, both because the dosing comes on so fast, and also most terminal or end of life patients are not usually a location that smoking is appropriate, because they're likely indoors and perhaps in some kind of a institutional setting. So when people ask you about, well, doc, should I get some cannabis flower to smoke? Well, how do you interpret that for them?
Mm-hmm. Yeah. I say the same thing you just said, and also the fact that with smoking, it doesn't last as long. It might be quick to come on, which actually can be nice and helpful. And for that reason, I try to, if a patient has the accessibility to have vaporizers, dry flower vaporizer, or a clean oil that's vaporizable without pesticides or solvents, and any excipients. So there are oils can be vaporized too, and inhalation can be really effective when you need relief, like now, and you don't need that much. So you're fast acting and titratable. As I'm sure your listeners know, there's so many advantages of that route, but the disadvantages are, like you said, context, environment that might not be conducive to that, and also the fact that your relief might not be as long lasting because the onset and fall off is short. So I just kind of educate patients about that, and that if you do smoke, the Institute of Medicine in '99, their earlier report on cannabis and in end of life care, they said that, the risks would be outweighed by the benefits would be outweighed with the risks of smoking in patients who are terminal or end of life. So we don't really, if a patient wants to do that and likes that and likes the flavor, the taste, that approach, and they have a setting that's conducive to that, I'm not gonna stop that because there are risks like soot, coughing, and of course you're mentioning the respiratory sensitive individuals in that earlier show you had on COPD. So those are the risks. But if they're okay with those things, and I still think it's worth supporting patients to do that. It's a very old method of use, and it might be part of their tradition. It might be part of their, the sensual aspects of cannabis. And I didn't get to mention that in the last section, that cannabis is also useful for patients at end of life on improving, their sense of being and just overall general psycho-emotional, spiritual wellness. And so anything that's going to help connect them to a tradition or a aroma that feels, comforting is great. So that's all the big caveat I would say to patients about that.
I like how you point that out about the tradition, culture, and the the emotional connection with flower, because it really is different, isn't it, between people who are learning about cannabis and starting to use it for the first time at end of life versus a lifelong user of cannabis who is using it at end of life. I have gone to so many patient events where, you've got these older folks who've been smoking weed their whole life, and, they look so much more at ease and in their realm when they've got a joint and they're smoking it. And for me, as an asthmatic, I'm like, all that combustion and all that heat, that's not, for me, that makes it harder to breathe and isn't great. But you see these folks, and like, it's been their release from anxiety and part of their social world for so long. I discourage people to, try to have those people switch to, something else, just because they are, dealing with end of life care, because you don't want to take from them something that they have been using effectively their entire life. They're going to get the muscle relaxation, the anti-anxiety, the increase in appetite. They're going to get the basics, whether or not they're, smoking and combusting a joint or using a vaporizer. But gosh, let them use it the way that they want to.
Yeah, exactly. Our philosophy is often don't take away what people it's already working for them, but maybe you can add to it or supplement, as long as it's safe. So then I would educate patients about the value of tinctures, or suppositories or method or oral edible route. If they aren't, that they could add that in and enhance the benefit that they're getting. So that's sort of how I approach that. Like it's both and, if possible.
And so before we move on from smoking, so I guess essentially the summary is if there's no health reason for the patient to stop smoking and they love smoking joints, let them, go about their way that they always have. But if there are lung issues, or if they might be allowed to do this indoors, consider a flower vaporizer, which, honestly, I've heard from so many patients who they just close their door and they vape in their room in an institution that's federally funded and it's not allowed, but because, vaporization isn't smoke, it doesn't get the same kind of attention from staff. And so, that's that. And so, be aware of vaporization as an option, but don't think it's the only option, just because somebody's sick. So let's move on to capsules. So, capsules are good for many patients because of the ease of use, right? There's no smell. It's discreet. It's very easy with the dexterity of the fingers, to just take a capsule versus, roll a joint or take tincture or things like that. But it's not so good for some folks with like throat and some stomach issues. So please speak to your experience about capsules.
Yeah, you got it. I mean, a capsule basically people talk about encapsulating in usually like cellulose capsules, various extracts of cannabis. Some people just use raw flour or heated up flour and ground up, cannabis flour, or more commonly an oil extraction, like a coconut oil extraction or a glycerin. And then or alcohol extraction, and then you just take a chunk of that and then fill it into a capsule, and there you have an encapsulated cannabis product, which as you said, it bypasses. It's not the lungs, it's not the oral mucosa. It goes straight to the stomach, and in the small intestine, it absorbs. The absorption is more variable. But it's longer lasting. And if you take it with a fatty meal, or oil, sip some oil, it'll improve the absorption ability. And then it has first pass effect through the liver. So you get more potent. And if you're working with THC, you get 11-hydroxy THC, which is more potent. And, you can have several hours of effectiveness. And, all you had to do was just swallow one capsule. So that's very convenient, and I think can do a lot of good for patients for the symptom clusters and that we were talking about before. So yeah, it's very. I think you're right. The swallowing challenges are there. I've had some patients, or I've heard about patients that just skip who have feeding tubes in, and I had a doctor who was a teacher of mine in medical school, and she told me stories how they would just, in the 80s, somebody who had used cannabis for nausea, vomiting, symptom relief, but couldn't swallow. So they made an oil and dripped it into the opening of the feeding tube. Yeah. So that's sometimes you got to just skip the entire upper GI and go straight to the opening that patients use. Yeah.
Wow, that's extraordinary. I've not heard of that before. One of the interesting things about capsules, and you hit on it just a moment ago, that there are some stomach issues that you have to avoid it, because even though cannabis is good for stomach issues, the capsule itself is irritating for lots of different types of patients. And so it's weird to say that, cannabis is great for stomach issues and digestive issues, which it is, but the method, the capsule itself, may be the irritant. So,
that's right.
Patients and caregivers, they'll get more sophisticated as we go with this. You mentioned a wide range of things that could be in capsules, from, just flour that has been put into a capsule, and then oils, and then whatever type of combinations that they might purchase at a recreational legal cannabis store. I think it's probably a good idea for us to mention that if you are interacting, if you're using capsules that are homemade versus capsules that are store bought, you're going to want to make sure that you take, at least one of these capsules, maybe a few, if you think that there might be a lot of variability to them, and go ahead and drop them off at a cannabis analytics lab. Hopefully, if you don't have one in your state, you'll have one soon. The point I'm trying to make is that dosage is very relevant when it comes to this, because one of the big aspects of medical cannabis is repeatability of results. You don't want to have a patient who is taking, a particular dosage of a cannabis product consistently, and then all of a sudden they take the 8th or 9th capsule and now they're over the moon high because there's so much variability in it. So I'm a big fan of people, making their own cannabis medicine, but would you agree that the repeatability of results is essential when it comes to this type of care?
Absolutely. Yeah, if you can get to a lab, if you're in a state where you have access as a patient or as a consumer, why not utilize it? It's good to know how much, at least the potency. There's other testing for safety too. If you got it from someplace and you're not sure of the pesticide content or heavy metal residue. So those are also important for safety purposes. And then potency is great too. So you can know, okay, I want to get 5 milligrams of THC and 25 milligrams of CBD, or I want to have a high THC, low CBD, or, I want to, some places offer terpene testing. So those kind of things will give you a chance to understand more about what your responsiveness is and what you might need to adjust to maximize the response you're looking for. So it's very helpful. Though it's hard some places don't have it, and sometimes the testing is expensive. So those are the limitations.
Sure. And while we're talking about limitations, let's hit on the limitations of capsules. We've already hit on the fact that the actual act of swallowing them can be an impediment for many patients. But also the putting them together, the actual physical capping them up is very likely going to be something that is going to be difficult for the patient. And gosh, it's also very possible that it's going to be difficult for the family members too, because making caps is not the easiest thing unless you've got, very fully functioning phalanges, and
there is a capsule making machines you can get, which sometimes patients benefit from simplifying their lives. It's like an auto capper.
Absolutely. And for somebody who is working in end of life care and it's not going to be immediate, that may make a lot of sense. The biggest drawback for me when recommending capsules to patients, though, is the fact that you're kind of tied to the preset dosage that's in the capsule. And I'm a big fan of variability in dosing from day to day based on the patient's needs, so they can titrate themselves. And for this, tinctures become very popular. What have you seen as far as like the benefits of a patient being able to control their dosage up or down based on their day?
Oh, well, that's very beneficial, especially when you're, struggling with getting your regimen right, or you're in the early phases. For patients who, kind of already know what their sweet spot is, what their, about amount of medicine that's going to improve their whatever symptom or global cluster they're treating, and then it's capsules can be a simple sort of fix. But if you haven't really nailed that down, there's nothing like the tincture to really help to kind of play with, okay, let me half a milliliter here or there, or a quarter mil in increments, just to kind of see what happens. And we call that auto-titration. It was back in the day when we were still fighting whether we can even have medical marijuana in all these states that we have it now. There was all this there would be the conservative establishment would say, oh well, gosh, there's no single dose, and that's terrible. Like, what kind of medicine is that? And then we'd go back and say, well, no, this is called auto-titration. You can the patient can self-adjust their dose based on what their need is and how they respond, because there's so much variability in, each individual patient's endocannabinoid tone, their absorption, their metabolism of different cannabinoids, and they're based on their genetic profile. So it's really it's a huge asset to cannabis medicine to have this ability to safely have little scales of sliding scales, so to speak.
It's interesting, too, how different patients use that variability, that sliding scale, differently than each other. For example, I have seen about the same number of patients who have a smaller dose of THC and a higher dose of CBG and CBD in the morning, and then maybe a little bit more by daytime as their body is getting a little more sore. And then by evening, when they've already, visited with their family and done whatever they have to productive or whatever during the day, and they get to the evening, they increase their dosage to decrease the stress on their body and just make their body more inhabitable. Whereas in that example where you start slow and you increase the dosage throughout the day, I've seen just as many patients go the opposite way, where they wake up in a great amount of discomfort, because for many of them it's from sleeping or being horizontal and not sitting up or whatever, and so they wake up in a great deal of discomfort, and so they start the day heavily, and then they slow down through the day, and then they increase again at night, so they can increase their cannabinoid load before they go to sleep. And it's that kind of variability which a lot of patients love about cannabis, right? Because you're just not really offered these options as a doctor in your situation, where you can really go up and down and give the patient so much control.
Oh, that's fascinating, Shango, that you've been able to see that kind of range of variable usage and effectiveness. That's just so fantastic to hear.
So when you are explaining variability of dosage, individualized medicine, and that the patient's in control, for most patients throughout their life, their relationship's been with the doctor is that the doctor tells you how much to take, and you're not supposed to deviate from that. But we all know that we all pretty much deviate from what the doctor tells us, and then we often are not clean about that with our doctor because because they're an authority figure. How do you go about explaining to a patient that they are in control of this medicine and they can take as much or as little as they want? How do you kind of get them past the taboo that they are in control and that they don't have to do it the way that they're being told?
Yeah, absolutely. I mean, I think a lot of what I'm coming from this integrative medicine background, where people are used to, having a little bit more autonomy or a little more involvement in their healthcare. And so that certain type of consumer or patient that has already, learned to listen to their body and to be more active in that pursuit. And cannabis is a traditional plant medicine, natural medicine, and that's, people grew their own and made their own products for thousands of years probably. And I think it's just just reminding people that this is not kryptonite, and that it's not going to be like you take too much and then you're going to go to the, fatal overdose, and, something like that like might happen if you're, trying some other more higher risk profile natural substances. Because there are definitely, if you take too much datura or something like that, you can have a really significant reaction, or other types of plant medicines that have value, but also have a narrow window. So it's emphasizing the safety, from the medical standpoint, is really important. And we're fighting, decades and decades of political and health politicized public health messaging on the extremely severe dangers of cannabis, so that even one micro fragment is enough to be so dangerous to society that somebody needs to be put away in jail. And that kind of reinforces that fear, and that let me be very, very cautious. The other thing I would say is that there's been kind of a proliferation of para-educators, para-health professional educators, who help patients with dosing, with titration, with kind of feedback. And so it's having somebody who you can kind of work with, who can help kind of guide you in a more, definitely you're still in control, but it's still nice to have a back and forth, to check yourself with, to get other ideas, other suggestions of medicine and product. And so I've found valuable for patients when I can refer them to a company or an educator that's doing that work and coming from a patient advocacy standpoint, where they're trying to empower with education. So that's another way to kind of be in between ground. It's not just the doctor and the patient. It can be like a team of with health educators.
I like that we keep on coming back to this team approach, because while this is becoming more and more popular, historically it's not really how Americans have interacted with the medical establishment. And I think that the more examples you give, the more apparent it is that this level of care that hospice patients are getting is so much higher. And it's so effective that it would really be great if we all had that. So let's talk about this last category of methods for using cannabis medicine, and that's suppositories. And while it always gets giggles when I speak about it publicly, when push comes to shove, it can cause so much symptom relief that it brings patients to tears, because they've gone through all of these different pharmaceuticals and they didn't reach the needs that they wanted. And so then everybody tells them they should try cannabis medicine, and generally, suppositories are not the first things suggested by friends, so they go through smoking, and maybe they'll go through capsules, and maybe they'll go through tinctures, and then they're finally like, what the hell, none of this stuff is working for me, but it's supposed to work, and it's working for other people, but because of their particular health issues, these other methods are not working. And so you can take an oil and make it into a suppository, and then when you insert it rectally, the capsule or the oil, so some people use like a frozen oil, pill, I guess I'd consider it. And then that melts, and the tissues on the walls of the rectum will absorb the oil. And the two biggest benefits that I find that are unique to it is, number one, it skips the stomach and whatever kind of problems could be going on in the stomach. But also, you can take a higher dosage of THC, as a suppository than you can otherwise for pain relief. So how do you see it actually play out first person? And I guess suppositories are rare enough that you may not have seen much of this firsthand, but perhaps you have. So what are your thoughts?
Well, I think it's really, I think you've pretty much said it all. We don't have as much, pharmacological data. Pharmacokinetic is what it's called, where you look at absorption and you kind of calculate how much is in the bloodstream as a function of how much you put into the suppository. that data is there as much as we have with other routes of administration. So it's there's a little bit more of a individualized or anecdotally driven recommendation pattern, which is fine. I think it's just we just need more learn more. I think like for example, I think the absorbability of CBD might be higher than THC, or actually I think the THC we have better data on than CBD. Let me put it that way in terms of absorption from the even the ability to absorb from the rectum. So, and then there are other issues with whether you're placing it in the right level in the rectum, because there's actually like the blood supply, and there's a like a line of tissue that separates one level of the rectum from another, and there might be some people might need even deeper insertion for better absorption, but then you really want to make sure you don't have anything in there that's going to cause any harm. Like it should really just be a dissolving like bullet shaped type like oil object. So the suppositories can be, there's more of an art to it, and I think I think you it's sort of like smoking, where you do bypass a lot of the liver effects at the first stage, so that's kind of nice. But you also get the longevity of effect, so that's also can be very helpful. So I think it's I have a less experience. I have patients that certainly use cannabis suppositories, and they're very happy with the effect. We prescribe other medicines via suppository, so it's not a new method to me. It's just that we don't have as much data on it with cannabis.
It's really interesting helping patients and their families. Once they've decided that suppositories are going to be their solution, it's amazing how much I've learned about suppositories just from trying to help families figure out how to do it, right? There are suppository kits online on eBay that you can pick up, and it's really funny. They look like, they look like ice trays, right? And people are putting, a little squirt of cannabis oil from a syringe and a little bit of shea butter and a little bit of coconut oil in there, and then tossing them in the freezer, which is like a really, really basic, recipe. And they get harder. And then once they take them out, they've got a few moments to, introduce it to the body before it warms up and gets, soft. And of course, that's always an interesting experience for the patient, to have something so chilly down there. But it's interesting. Like, I find that more and more people are realizing that a lot of, just regular old capsules, like you'd buy at the pharmacy, just like empty, number 3 capsules, they as well will, disintegrate in the rectum, and it really doesn't have to, you don't really necessarily have to go down this path of, building your own, reinventing suppositories.
Right.
But it's a whole rabbit hole of its own,
Yeah, I think it's, we need more data. But I think I'm really happy to hear that patients are making their own products and exploring it. And I think a lot of folks are also interested in this for disease modification, to get the higher number of milligrams to see if that will help to change the course of their cancer. And I think it's harder. We need more information to find out exactly how much is coming out of there into the bloodstream, so that we can, help guide better. And I think we're going to find not everything absorbs the same way that that you get in the small intestine. So it's going to be. I don't know. Hopefully, somebody is going to do those studies.
So what advice do you have for folks who are going to use different methods together? So say they're going to use capsules and smoking, or vaporizing and a tincture, or one of the others in suppositories, because in taking them these different ways, you have issues with, timing of when it hits your body, and also having to do the math of your dosage. You've got a lot of experience with, a variety of medicines and stacking them, right? So how do you teach that to patients?
Yeah, it's pretty much like you want to have what we're talking with end of life patients, so oftentimes a lot of symptom burden that's just going to be there throughout the day. So it's useful to have a kind of a workhorse, something that's giving you a steady state, or more, long-acting effect, and that's like we talked about, tinctures or capsules, and then you can think of other methods, vaping, and even suppositories as kind of a shorter acting like breakthrough, or something that you can layer on top of that longer acting workhorse. So I like to think of it that way, to help patients understand that there's something you're going to kind of need at the basal level, and then what else do you need when you need something beyond that. And that's sort of a good way to think about it.
Yeah, that's a really good idea. Have the one be your central solution, and then have these extras that you might add as needed. Do you normally recommend that patients keep some sort of dosing journal too?
Yes, that's very helpful, especially when you're trying to figure things out and seeing what's working, not working. And of course, with the, this is a complex botanical medicine with, it's not just one active ingredient. So the more you also know about, what percentage or consistency or potency material you're putting in your body. So making note of that, quantity and time of day, will, and if you have, you can put on the columns, okay, these are the symptoms I'm treating, and this is what it was before, and this is what it was after in terms of, severity on a 1 to 10 scale, for example. So that kind of data can be really, you can do that over like 5 days and you get a lot of information and show that to your, to whoever's helping you with dosing, and because it can become a lot, but this is just really to help make sense of everything. And there's just so many products is the problem too, so people kind of get overwhelmed, and that's where starting with at least like one, that's one, and then another layer on top of it, and then keeping notes will help to simplify this. And this is just the idea is just to sort of dial this in, so that then you can move on with your life, and do the things that you want to do. And the other thing I didn't mention in the previous section about the details on cannabis is in end of life care, there may not be like a set dosing pattern. Just it might be like people just are finding something that helps them with their mood, and they use that, or they use it when they like to, because their mood varies throughout the day, or their level of interaction with people changes, or they get fatigued after a certain amount of time, or they use it for energy. So sometimes it can just be a really like, okay, let me just have these on hand, and I kind of know what they all do and what they're all good for, and so let me just sort of mix and match, so that's also another, like, I don't want to like make it so complicated and like programmed, it should be a chance to also have a spontaneous kind of empowerment toolkit.
Yeah. Excellent. Oh, I like that. An empowerment toolkit. Yeah. I like that. So, it's not uncommon to hear from a patient, 3 months into this process that, the cannabis just isn't working like it used to anymore. And it's one of the challenges with cannabis medicine that over time, the human body can develop tolerance. Would you explain a little bit about, tolerance to cannabis and what kind of advice you give your, patients about manipulating their doses or taking tolerance breaks?
Absolutely. I mean, I've my colleague, Dr. Dustin Sulak in Maine, is an amazing osteopathic physician and cannabis researcher and scholar. He has made such a nice websites and patient literature and videos about his resensitization protocols. I just always refer my patients, please go listen to Dr. Sulak's lectures or videos about this. He has a website, healer.com. And so I just have him do the explanation. But I mean, what he's explaining to people basically in a bottom line is that your CB1 receptors, even CB2, but any receptor, which is the protein on the cells that on the surface of the cells, like of nerve cells, for example, that cannabinoids from cannabis, bind to and signal through to cause the downstream effect of modulating excitability, whether it's like, overactive pain circuits, overactive vomiting circuit, or, boosting up the activity of neurons that are involved in mood, or slowing down the activity of neurons that are involved in negative thoughts. All that kind of modulation that is through those receptors, through tickling or binding to those receptors. And, if you just keep pushing and pushing and pushing cannabinoids for a long period of time, those receptors can get desensitized. And that means that they don't make as many of them, or, it's usually that, like they just kind of come back into the cell membrane rather than being out there ready to receive signals. So it's a dynamic system. So if you kind of take a break from the cannabinoid exposure or take holidays, follow different protocols that Dr. Shulak has advised, you can really just resensitize the whole system. It can kind of reboot nicely. So that's the solution there. And on the extreme, sometimes you take too much. Not only is it not working, it can actually make things worse. There's something called the cannabinoid hyperemesis syndrome, which is more rare, but it does happen. I do see it in my practice, and we think that there's the body is like having an overactive immune response to all these cannabinoids and ends up making an antibody. This is one theory that kind of might be blocking the receptors and ending up giving you more nausea and vomiting rather than less. So that's kind of the everything is in moderation. So that's where if cannabis isn't working as well, it's also possible that other therapies might be helpful. Cannabis is not a complete medicine. It's certainly a holistic medicine. It can do a lot of things, but there are also other natural medicines out there and other strategies that can synergize with cannabinoids. So that's the other thing I would say about that.
So let's take that and go the other direction with it. What kind of interaction with other drugs have you seen in your practice between, the pharmaceuticals that there may be and then using cannabis?
Well, the most common one that I see in my type of practice is the combination of cannabinoids and opioids. And this is opioids are derived from opium poppy, like morphine, codeine, and then derivatives from thebaine, which is another ingredient. Anyway, there's a whole class of opioids. Maybe people have heard about hydrocodone, hydromorphone, Dilaudid, fentanyl, there's a long list. Those medicines can be helpful for pain, but if they're the only ones you rely on, they have also significant problems with tolerance, with dependency, with constipation, with suppression of adrenal access with long-term use. So if there's any way that you can make the dosing of those more effective, like, that you take cannabinoids and layer that with opioids and the pain relief is synergistic or greater or lasts longer, that's kind of the one of the drug interactions that is very positive and actually has been studied in clinical trials, and we know it's a real phenomenon, and it actually probably makes opioids safer because the blood level of the opioids also comes down, which lowers the chance for having an overdose. So that's kind of a big one that I see a lot. There's long tables of drug interactions, and of cannabinoids, one of the ones that was really pointed out with the introduction of high-dose CBD on the market, Epidiolex, the tincture of cannabis that is used in seizure disorders, FDA approved for that. They go on pretty high doses, or they can go on pretty high doses of CBD, like hundreds and hundreds of milligrams per day. And at that level, it can impact your ability to metabolize other anti-seizure medicines that your doctor might have prescribed. One of them is called clobazam. It's as well known, or our trade name is Onfi. And if you take a lot of CBD with Onfi, the Onfi levels become more toxic in the body, and so they have to be monitored more closely. And that's been shown in these studies. And that does come up from time to time. I have patients who have seizure disorders who come to see me for advice, and they're taking Onfi. So we always monitor the blood levels of Onfi while we're titrating up cannabinoids, so that we know that we're in a safe range. So that it's kind of like on one hand, I can count some of the major issues in general. Cannabinoids play well with others from most medicines. So I think it's just a matter of what can you mix it with. Therapeutically, I think there's a lot more to talk about in terms of what can you mix it with, or what can it help to reduce the amount of reliance on. I'm not a purist. I think it's nice to use other medicines if you need them, but maybe cannabis will help to reduce the dose of those medicines.
Excellent. Fantastic. Well, were you done?
Yeah.
All right, fantastic. So during the third set, we're going to talk about trying to use cannabis medicine in real life. So far, we've talked a lot about, the theoreticals and the ideal situation. But after the break, we're going to talk about, resistance by the family and resistance by the care facility, which is its own thing to tackle. So we will be right back. You are listening to Shaping Fire, and my guest today is hospice and palliative care specialist, Dr. Sunil Aggawal. This message is for folks who grow cannabis. I'm talking to home growers, patients, and commercial growers too. I'm probably talking to you. When you plan out your next growing cycle, be sure to check out Humboldt CSI seeds at HumboldtCSI.com. Caleb Inspecta and his family have lived in Humboldt County for over 100 years. For the last 40 years, 3 generations of his family have cultivated extraordinary Sensimilla cannabis in Humboldt, Mendocino, and Trinity counties. Because of his lineage and the hard-earned experience that comes from growing up, smoking, and sifting large populations of cannabis plants in Northern California, the seeds you'll cop from CSI will be winning genetics based on longtime heavy hitters and updated and resifted to bring out new and exotic traits and better yields. Go ahead and ask around. Caleb, also known as Inspecta and Pirates of the Emerald Triangle, is a breeder's breeder. He reaches way back and works with significant strains, recreating them in new and interesting ways that you'll love as a toker and a grower, as well as offering you some surprises that will delight serious seed traders and cultivators. Humboldt CSI goes a further step and selfs all these chemovars so you know all the seeds will be female. These are not experimental feminized seeds. Humboldt CSI releases some of the best female seeds available anywhere, and it will show in your garden. Folks grew quite a bit of CSI Humboldt genetics last year here on Vashon Island, and everyone was pleased. The patients had beautiful female plants and didn't have to cull half of their garden as males. The folks growing for the fun of getting high grew colorful flowers with exceptional bag appeal and great highs. And breeders had 7 out of 7 females in a pack, which gave them a lot of phenotypic choices. Take a moment right now and visit HumboldtCSI.com. You'll find an up-to-date menu of both feminized and regular lines, along with photos and descriptions. That's HumboldtCSI.com. Pre-rolls have come a long way since the early days of normalization. When you choose Saints Joints, you are smoking all-flower, top-shelf pre-rolls with terpenes that will sculpt your high in a way that dry, old pre-rolls just can't. Whereas most brands release pre-rolls as an afterthought, for the last 5 years, Saints Joints has focused on their line of exotic, curated joints. And while some companies just chase the hype strains, Saints Joints goes deeper, searching out hard-to-find strains, unexpected crosses, and nearly forgotten land races and classics. And some hype ones too. Not only does a joint from Saints smoke incredibly well, they have fine-tuned every step of the process so you don't get runs in the paper, the joint is just the right density to have a nice pull, and the joint stays lit, even if you get a bit chatty. Saints Joints boxes are works of art and will spark conversation when you pull them out at a party. Saints award-winning boxes change with every release, feature edgy outsider art, and often raise awareness of important issues like equal rights. Saints boxes are so desired that many collect them and display them in their homes. Ask your bud tender for Saints Joints and have a premium joint experience. Now, if you are a licensed cannabis cultivator, I have an extra message for you. Saints is looking for partners in legal cannabis states to expand the availability of the Saints Joints brand. Do you grow exceptional cannabis flower but are less excited about all the effort, cost, and risk of launching your own brand? Saints Joints may be just the partner you are looking for. Already established in California, Washington, and Oklahoma, and recognized by Entrepreneur Magazine and Green Entrepreneur as a cannabis industry leader, the Saints Joints brand will set you apart in your home market. The best thing I can recommend is for you to visit their Instagram at Saints Joints and look at their patented drawer design boxes. Become that brand everyone is talking about without having to build it from scratch. Check out the Instagram at Saints Joints and then visit saintsjoints.com to find out more. In times like these, when so many cannabis companies are growing their flower in gigantic warehouses and fields using synthetic nutrients, it is good to know that there are authentic California heritage growers using natural farming techniques and sunshine to cultivate cannabis flowers for you. California has produced the best cannabis in the world for generations, and the idea that massively scaled industrial cannabis production could produce the same quality as small batch, lovingly cultivated flowers is just silly. Moontime Medicinals is located in Humboldt County on the lush South Fork of the Eel River watershed in the epicenter of the American cannabis heartland. Moontime Medicinals grows under bright California sun in greenhouses using only natural farming techniques like hugelkultur, compost teas, whole food fertilizers, and fermented plant juices. Every part of their growing process plays its own part in nature, and nothing synthetic is injected into the process. The result is big, beautiful cannabis flowers with wide-ranging terpene profiles that taste like great cannabis should. If you live in California, ask your bud tender for Moontime Medicinals and visit Moontime Medicinals on the web and Instagram. Moontime Medicinals is also available as part of the Redwood Roots family. Moontime's whole flowers appear in Redwood Roots curated joint packs alongside other heritage cannabis cultivators like Lady Sativa Farm, Ridgeline Farms, Humboldt Redwood Healing, and others. Moontime Medicinals, top shelf cannabis grown in harmony with nature. Welcome back. You are listening to Shaping Fire. I'm your host, Shango Los, and our guest this week is hospice and palliative care specialist, Dr. Sunil Aggawal. So, Sunil, we've talked a lot so far about, the why and the how of cannabis medicine in kind of like an idealized environment, but we both know that, when it gets down to the moment of helping a patient, there are challenges and hoops that we have to jump through to make it work. So, number one on that list is usually resistance by the family, right? Because we've had, 70 plus years of federal resistance to cannabis medicine, and it's taboo, and a lot of people do not feel comfortable having their parent or loved one using cannabis, which they are unfamiliar with and may have some societal beliefs against. I figure you probably run into that all the time because you have such an integrative approach. You use a lot of stuff that people don't even know what it is. And so how do you normally approach a family? Do you normally, I guess this probably has a lot to do with the state of the patient, but I'm just going to kind of set it up for you. Do you normally talk to the patient first or the family first? When you know that cannabis is going to be a helpful thing if used properly, how do you go about introducing it and working with a family that may be resistant?
Mm-hmm. Yeah, well, it's the first thing I always try to do is to name what it is, what the barrier is in this case, and putting a name on it makes it a little bit more, tangible, understandable, contextualizes it into the larger social fabric of a patient and family's life, other issues in society where we face discrimination based on, age, gender, race, religion, all the different things that unfortunately we still are living with and are trying to systemically address. So, and that term is stigma. the issue of stigma, which is tied to shame and fear and ostracization. That's what stigma comes from. This idea of being marked, a stigmata, a mark that kind of makes you ostracized or socially outcast. And so there's a stigma of cannabis that persists, and that was engineered or pushed by the government for a long time. Not that there wasn't. There's always been kind of in puritanical settings some concern about substances that change your ordinary state of mind. And so I think people just need to understand that can be done safely and appropriately in a accepted context that's safe and healing. And so after you talk about, you say this is stigma that you're facing, and if a patient tells me that they'd love to try this, but their loved one is really doesn't see it that way, or they'll put limits. I've had some loved ones, patients tell me, oh well, my siblings, older siblings of somebody who has a lifelong disability, she has siblings that's helps looked after her, but one of the siblings is really in favor of cannabis, the other ones are not, and so they kind of don't go as far as they could go in terms of what could help the patient. So things like that I come across, and I always tell patients, listen, I'm happy to have a family meeting, a conversation with your family members to help them address their concerns or questions that they have about this. It's stigma, and it's something that we should talk about. It's usually grounded in some ignorance or lack of knowledge, and there's fear too, and that's sort of the other angle, is that sometimes the fear is sort of warranted, in terms of actual legal repercussions that can befall a family or a patient that they're concerned about. And that's where the other context around, well, what is exactly what are the legal issues here, who's making the rules and who's enforcing those rules, and how, is there any way we can find medical exemptions or exceptions, or utilizing that angle of medical care, where you have to advocate for a patient's rights or their patient's needs, and if the laws and rules are impinging on medicine, then which social worker do we need to call, which lawyer do we need to call, who do we need to write a letter to, how can we overcome that barrier. So that's sort of how I family conversation, identifying stigma, talking with the family, inviting, educating, and then, if there are real barriers like legal or administrative barriers, trying to address those with a team approach and medical and letters if needed.
It is interesting how, even though the family is coming to you for expert advice, how often they will then try to create the ground rules for within which you work. So, for example, it's not uncommon for a family to say, yeah, we're okay with cannabis medicine, but only CBD and not THC. But they don't really understand that THC, even at low doses that don't cause euphoria, are still, THC is generally going to be part of a healing process when it comes to cannabis medicine.
Yeah, that's right. That's those kind of the CBD only, is a THC stigma is even more specific, and that's also requires the same approach.
When you need to interact with a family and they say, yeah, let's do a family meeting, it's hard, right? Because you've got all these different communication styles of all these different people, and you might, the patient probably knows you decently, and maybe the spouse, or maybe the one child who is kind of running point for the family knows you pretty well, but then you've got all these new people in the room or on the Zoom call or whatever, and they don't know you, and you're like, oh my gosh, how am I going to communicate to this room where I've got all these varying people? How do you deal with that, Sunil?
Yeah. Well, these are things that they teach us a little bit about in hospice and palliative medicine training, fellowship training, and it really just the research shows that the more that family members speak in meetings, have an opportunity to actually be heard and to speak rather than being spoken to, improves their satisfaction with the experience. So it's really more about creating a venue, a space, a platform for family members to listen to each other, and to be heard about their concerns. So asking open-ended questions and certainly leading the meeting, but giving a lot of space for people to kind of state their concerns and then if there are emotional aspects in their concerns, oftentimes there are very strong emotional issues, fear, like I was mentioning, or the shame, or the tied to stigma, or whatever it might be. Then naming those emotions. Like I can understand, I can hear your frustration, I can hear that you're worried, and that helps to improve the communication, name the concerns, and start to hopefully move towards if this is actually something a patient needs, and then being the advocate for the patient as a doctor, and giving the advice. That's my recommendation, and then seeing what people say. So that's how to approach those. There's an art to that.
I would think that clinical doctors, that is one of the key tools in their toolbox is communication skills, because certainly somebody who's interacting with family all the time is going to need a different version of communication skills than a research doctor, right? Who still needs to know how to interact with people, but it's a lot different dealing with the folks in a lab versus family members who are dealing with a end of life patient, because they've got all their own emotions are all on like hyper then, because they're freaked out and they're trying to review their life's history with this person, and they got their own taboos. Oh my gosh, what a soup of a mess.
Yeah, you got it. And that is our in my field, hospice and palliative care, communication is really one of the critical skill sets that we work on, because it's very important to deal with, to even figure out what's going on with a patient, how you can better help their distress levels, or the family, or sometimes I'm involved in helping them develop the care goals, like whether they should go this way, take that treatment, take this treatment, or focus more on a fully palliative approach. Like trying to sort that out requires a lot of ability to understand the various competing interests that are involved in trying to center what the patient's values are. So it is and in general, I would say when it comes to cannabis discussions and talking about this stigma, if people are ready to sit down and talk about it, we've already made huge progress. I remember when the state of Washington had no legal access to cannabis, until this law passed. I mean, they had medical marijuana, but they didn't have adult use. And the big campaign that the ACLU ran was marijuana. It's time for a conversation, and it was this whole idea: hey, we can sit down and talk about this. We can sort of change some of our preconceived notions, and that was kind of a brilliant stroke. And I think the same thing is true in the individual context with family.
It is often frustrating, because even when you have a family that is totally into it, and they're modern, they're open-minded, and they're actually thinking about what's best for the patient, then you've got resistance from the care facility, because generally they accept federal money and therefore are beholden to federal laws. I can imagine that as a integrative caregiver, that running up against that barrier causes you unending amounts of frustration.
Oh, well, yeah. I mean, again, as I mentioned earlier in our podcast, I've seen a nice amount of change in the greater, healthcare environment, residential care facility environment, in the 20 years or so that I've been thinking about this topic and being in clinical settings, I would say. So I think so to add to that, like I've had examples of where I've had privately owned chains of assisted living or end of life residential care facilities, which have a lot of older population. Like one I'll just name is Aegis Living, AEGIS, Aegis Living. They're huge. They're in multiple states. They, like I would say 5 years ago or something like that, worked out a policy for, allowing cannabis in their facility, and I've seen other facilities that are privately owned also that allow their nurses to handle cannabis that patients bring in. Their care staff if they're getting help with medicines, and so I've kind of interacted with clusters of facilities that chose to not be beholden to some of the federal rules, even though their patients might be on, Medicare or receiving some federal benefits. And it's probably because they're, independent, or largely independent. But there's always still some overlap. There's always some federal regulations, state regulations involved in all of these facilities. And so it's just a matter of like, well, is it enough to make a difference, or are we just using that as an excuse, to just sort of punt the issue? And so I've been very heartened by the fact that some of these facilities develop their own internal policies. In general, they'll say no to smoking cannabis. They'll say non-smoked products. They'll say that the patient needs to have a medical cannabis authorization, and that things need to be labeled and this and that. So, sometimes security around the product. So, like a secure storage. So that's where I think I've seen some changes now. And then the other place that I struggle a lot on this with was the hospital. The hospital is really like the center of advanced high-tech medical care and lots of regulations on hospitals. And many times patients would sneak things in and just sort of, the hospital didn't want the liability of saying, okay, well, you had something happen to you and it's a medicine that we did not give you or authorize, so we just don't want you on it. And so that kind of like legal impasse prevented a lot of acceptance and stigmatizing environment to use cannabis in, even though when patients might be hospitalized for things where cannabis could actually help their symptoms. So I would, oftentimes prescribe like THC pills, to patients from the pharmacy. So as a way to, use some aspect of cannabis in a legal framework. But now I've seen there are some hospitals that are allowing cannabis in their wards, not everywhere, but it's changed. I had patients at Children's Hospital in the last couple of years where they also are allowing children to bring in cannabis that their parents are bringing in and administering, as long as they've gone through some kind of approval process that they have on the inside, which goes through their pediatric attending doctor and some regulatory setup. And it changes the stigma significantly. The child now, and family members don't have to hide it. And it's I've had some patients where they put it on the whiteboard. Their family members are writing on like, this is what we're doing. And so that's been kind of a changing. There is an opening there happening, I would say, in the hospitals. And then I contacted the Department of Health in Washington, and they had said, oh, we don't have any problems to patients using cannabis in facilities. Like it's not anything that the state of Washington is limiting. They have granted these rights to patients. And so anyway, it's kind of all of that said, there are definitely facilities that are still out there that are far more tied into federal pools of money, and just say, hey, we don't allow that here. And in those cases, patients have to be, discreet.
This is probably a good point for us to give a loving shout out to nurses, right? Because there is no doubt that nurses, their creativity and hearts and knowledge are there at the center of these decisions between the doctor and the family and sometimes the gray market, right? So often I have come across nurses who are all like, okay, I've got a patient who uses cannabis at home. They're in hospice, but they're moving into the facility now, and I'm trying to move move their medicine into the facility, what are the methods that are most discreet? And, I play that role. I can share with them. It's for them and the family to decide, right? But nurses play such an important role in making sure that the patient gets the care that the patient wants.
Oh, that's amen. Amen to nurses. They have definitely played a critical role. There's one nurse who's been a huge leader in the national, American Nurses Association, which is the largest organization of nurses. Her name is Mary Lynn Mathry. And she has, been a huge leader for decades on cannabis and medicine, starting professional education, doing her own research about her own master's research when she was in graduate school about cannabis, and talking to doctors and how it's important to have open lines of communication. So I just wanted to put a shout out to Mary Lynn because. And then, of course, many, many nurses have now come forth and started cannabis nursing associations and all across the country. And they've really taken the mantle on to advocate for patients and to kind of help them toe that line.
Yeah, for family members who are listening, who are thinking about going in this direction with their family, I'd highly recommend finding a nurse that is educated in pro-cannabis as an ally, because you're not going to do anything that's going to be more effective towards winning than allying with a good nurse.
That's right.
Yeah. So Sunil, before we wrap up here, I've heard you speak a number of times, and one of the things that I really enjoy is when you get to the part of your presentation where you talk about humans having a right to use healing plants. And, certainly cannabis has been, taboo for many decades, but before that, it was 70% of the pharmacopoeia. We used it for everything. And then it fell out of favor with the government because it was used as a scare tactic, and so now everything's kind of a mess, and it's slowly coming back. But at the end, this is a plant that's naturally occurring, and I'd just like you to speak to the idea that that the plant is naturally occurring, and it's something that we should have as an option as a patient at any point in our life.
Well, you said it. Amen. I mean, there's no. I don't think there's. I don't think there's much else to say. It's simply the fact that we are. I mean, my area of interest is the human-environment relationship, and that's I came into medicine having a background in geography, the human-environment relationship, and how it applies to health and disease, to access to the therapeutic resources, the healing power of natural landscapes and nature, and all this critical ecology that we're part of that determines illness and access to health resources. So it's health and the environment is integral to our to who we are as humans, to our evolution, our connection to all other life on the planet. I mean, we are cannabis and humans are, and all these plants are actually like distant cousins on the evolutionary tree of life. So it to me was always very the idea that you have a natural right to the bounties or to natural plant resources is a very old concept in law, and I don't know, I think it's called natural rights, and the idea that the state, what is the compelling interest of the state to limit somebody's right to access natural resources, and that's where that's a social contract question. It's like, well, what limits are there for example, safety or resource conservation. So, you might say, oh, well, if everybody took all the firewood from this area, then the wood, collected as much as they wanted, then there'd be none left for everyone's needs, and so there has to be a limit. Or if you say, I don't want people collecting this particular rare rare bird or making these kind of endangered species pets, because this species is at risk of extinction. There's this huge global social reason to withhold trading in endangered species and conserving resources that are very limited. And that's pretty much the limits that we play. And then I guess the other one would be like how much ricin can you make? Ricin is a naturally occurring like bioterrorism, biotoxin that you can grow from plants, and so there's limits on that for the safety of people's ability to be free from bioterrorism attacks. So those are really the idea that there's these plant medicines that are going to be so dangerous for you that you're going to abuse them so much, and they're so unsafe, and we have to take them away from people. That's the sort of overreach that infringes on that natural right, and people have to really ask the question: is there a compelling interest of the government to limit this natural connection, or to completely, in the case of cannabis or in these other natural medicines, like completely remove it from entirely sever the relationship, like legally speaking. There's no legal context. There's no legal way that you can have a connection with these natural medicinal plants, and that to me is what it comes down to. Do we really think that that's a valid reach of our government? And is there a compelling? And that comes down to, well, what is the argument they're making? They're saying it's very unsafe and dangerous, and I think that's been proven wrong. So and the fact that there's a long traditional history of use already should have proven that a long time ago. And I think that's the mess that you talked about, that we kind of took these allowed the government to take these steps of overreach for naked, racist, political, economic interest purposes. And I'm sure some people along the way were convinced that there was, some real danger here, and we're doing this to, save the children, to protect our future, to like getting rid of lead paint and lead gasoline, but this is not that. And that's really where, if we don't have a historical context, if we don't have knowledge of our traditions, and we don't have a appreciation and reverence for the right to access and be connected to nature, we were gonna just kind of give that up entirely. And that's really, I think that's where one of the struggles that I'm very passionate about, and I appreciate your asking me. And it's not, cannabis is one, but there's a whole family of psychoactive biota, entheogen, natural psilocybin mushrooms, and like ergot fungus that has lysergic acid in it, or we mentioned peyote, which has mescaline in it, ayahuasca, which has a DMT in it, and these are all substances that all these natural plants have chemicals in them that are like our brain's neurotransmitters. You can call them neurotransmitter analogs, and so nature has provided these amazing substances that are, fit like locks and keys in our body, and that's no surprise because we're all evolutionarily connected. So, anyway, it's just kind of I think we're having a crisis of connection to the world and to our own connection to the natural world, and a sense that the government has passed laws that have tried to break that connection, and that's where we're trying to get back on footing, and I think as a doctor, I think without addressing this problem, we're never really going to achieve a public health a modicum of public health that we can.
That's fantastic and so well put. Sunil, thank you so much. Well, let me say, I got a couple things to thank you for. Of course, thank you for sharing your incredibly valuable time with us, and thank you for sharing your experience. And also, just thank you on behalf of all of the patients that you bring your integrative approach to, for, being willing to think outside the box and, to be able to open your heart and experience, with the goal of decreasing suffering. It's always a pleasure to interact with you because interacting with a doctor who is truly dedicated to helping the patient instead of checking boxes, it always feels really good. So thank you for sharing everything that you have, Sunil.
You're most welcome. It's been a great honor and pleasure to work with you. And I hope we do future episodes.
Fantastic. So if you want to find out more about Dr. Sunil Aggawal, you can go to the website for his clinic, and that's at aimsinstitute.net. That's AIMS institute.net. And also, I recommend that you go back and you check out all the way back to episode number 3 of Shaping Fire. Sunil joined me. He mentioned earlier that he was and is a geography buff, but we did this fantastic episode on the geographical history of cannabis medicine. And if you're, it doesn't matter if you're just getting to know cannabis medicine or if you've been following cannabis for a long time. This episode is just great to give you an idea globally how cannabis has evolved in its relationship with humans. And also, I want to remind you of the 6 episodes that I mentioned earlier in the show on the various ailments that you can find out very specific dosing information. And you can find all of those shows either where you downloaded this episode or at the website at shapingfire.com. You can find more episodes of the Shaping Fire podcast and subscribe to the show at shapingfire.com and wherever you get your podcasts. If you enjoyed the show, we'd really appreciate it if you would leave a positive review of the podcast wherever you download. Your review will help others find the show so they can enjoy it too. On the Shaping Fire website, you can also subscribe to the newsletter for insights into the latest cannabis news, exclusive videos, and giveaways. On the Shaping Fire website, you'll also find transcripts of today's podcast as well. Be sure to follow on Instagram for all original content not found on the podcast. That's at Shaping Fire and at Shango Los on Instagram. Be sure to check out the Shaping Fire YouTube channel for exclusive interviews, farm tours, and cannabis lectures. Does your company want to reach our national audience of cannabis enthusiasts? Email hotspot@shapingfire.com to find out how. Thanks for listening to Shaping Fire. I've been your host, Shango Los.